Hello, my name is Richard Sekel, and today's topic for the Australian Medico-Legal College's syllabus on how to undertake IME, that is Independent Medical Examination, reports and assessments. I'm going to be talking about on the assessment of causation in compensable injuries. Obviously, as always in all other forms of medicine, IME consultants must remain professional, objective, honest, balanced, very important to be balanced, fair, unbiased, comprehensive, covering all matters, not trying to skip over issues that might be important to one side but not the other. And of course, as always, professional ethics, avoiding harm, courtesy, respect, modesty, etc. Remain paramount in IME work as it does in all other forms of medicine. When talking about causation, there is somewhat of a difference between what doctors commonly are interested in causation compared to what lawyers and insurers and others might also consider as important. We generally are not particularly concerned whether the accident occurred in a particular manner or under certain circumstances. We are much more interested in what is the diagnosis and the methods of treatment, whereas lawyers and insurers, etc., also need to take into account many other factors in their legal causation for which they need proof of evidence. So in this arena, unlike in our clinical work, in this arena we are persuasive, but we are not the final arbiters in IME work. We are often asked to comment on causation, but the questions regarding causation can vary considerably. For example, we might be asked whether this is a new injury or an aggravation, that is permanent worsening of a pre-existing medical condition, or whether it's an exacerbation, which the AMA guides defines as a temporary worsening, and therefore if it's only an exacerbation, there is no permanent aggravation, and therefore there is 0% increased permanent impairment. Or it might be acceleration, that we're hastening the start of the symptoms or the disease. Or precipitation, that is, there was a prior condition, but it was asymptomatic, and it's now become symptomatic as a result of the injury. Or recurrence, which is actually just this previous condition that was coming and going, and it's just recommenced, but as a continuation of the pre-existing condition, and therefore not a new injury. Proof. It's important for us to understand the needs of proof for the people for whom we're providing information, that is essentially the courts, or if not the courts, then other arbiters, and we should be providing information fairly and equally no matter who is asking the question of proof. So it's very important that we understand that in virtually all of the arenas in which we are providing IME information, they need to deal with probability, not just possibility. For example, we know that if something is slightly possible, we need to consider it in clinical medicine, but in IME work, unless it is more likely than not, in other words, unless it is probable, which means greater than 50% likelihood to exist, then it's not an issue to be assessed. There is a law of logical argument that anything is possible if you don't know what you're talking about. That's important for us to keep that in mind, that we don't fall into that trap. There's another trap as well. The Latin word is post hoc ergo propter hoc, which means after this and therefore caused by this. For example, I picked up a pen from my solicitor's floor and I then felt backache, therefore I'm suing my solicitor. Of course, we all know that's ludicrous, but although that extreme circumstance might never occur, similar circumstances which are effectively just as ludicrous do often occur in IME work. As we all know, as medical practitioners, most disorders are constitutional. That is just part of the human condition. So we should not get tricked by the statement that others might put to us, "Doctor, if you can't say what caused it, it must be from work." That's a little bit like, when did you stop beating your wife? Clearly that's not correct under all circumstances. The expert, the concept of the expert. We are all being considered as experts when doing IME work, medical experts, within our areas of expertise. There was a ruling about 50 years ago in the California Supreme Court but it's often quoted still now in Australian courts, and that is that the opinion of an expert is no better than the reasons upon which it's based. And the lawyers refer to reasons, where we as doctors, using the same concept, refer to facts or medical evidence. So the lawyers need for us not just to say, because I am Professor so-and-so, or because I've been doing this work all my life, my opinion holds sway. No, that's of no use. Our opinions are only of value because we have gained extreme amounts of knowledge on a particular area and can use that evidence-based knowledge. So we should be providing always evidence, what the lawyers refer to as reasons, not opinions. For example, it's strongly recommended that we don't use this expression that in fact many doctors do use, that it is my opinion that something or other. Rather than saying it is my opinion, even I'm not interested in my opinion, all I'm interested in is the evidence. So rather than saying it is my opinion that, I would strongly suggest that we always use the words based on all of the evidence listed above, having provided that evidence, and then you give the opinion. Based on all of the evidence listed above, X exists. So I've talked about balance of probabilities again. In clinical medicine, of course, we can't afford to just accept that if it's slightly more possible than not, that is slightly more probable than not, that's where our investigations end. In clinical medicine, we clearly have to continue to investigate and investigate until we come up with as close to the 100% certainty of diagnosis as possible, and then in treatment as well, ensure that we're giving as close to as certain as possible the level of treatment. Whereas in compensation medicine, in IME work, we only have one chance at seeing a person in many circumstances, and we can only give a more likely than not, it's more likely than not that A exists than B, and that's as good as we can get. So we should therefore always give a clear, unequivocal opinion or statement of whatever it is that's being asked of us, rather than saying it could be this or it could be that. Being equivocal offers no help to anybody, whereas stating it is more likely than not helps everybody. Now, I'm not going to go through this heavy slide. You can pause your video and have a look at it. Bradford Hill, approximately 40 years ago, created a whole criteria of causation in medicine. Is there a temporal relationship by time? How strong is the relationship as measured by statistical tests that we understand? Dose-response relationship, is it a condition where the more contact there is, the more likelihood it will occur? Is it consistent in different types of studies? Is it a plausible association, and so on? But I won't go through all of those, but when we're talking about causation, it's very important that we remain mindful of these series of criteria that were very intelligently put together in terms of causation in regard to medical conditions. Similarly, NIOSH, the National Institute of Occupational Safety and Health in the US, and the American College of Occupational Environmental Medicine put together a similar sort of series of steps to determine the work-relatedness of a condition, of a medical condition. And again, I won't go through those, you can read those carefully, but they're all, in theory, what we would normally be doing in our medical practice, but very often we are able to skip steps. But in IME work, independent medical work, it's really important that we follow those steps, and that all of those steps do apply to the best of our ability. So when we're covering the question, is a condition genuinely compensable? To determine causation, we have to use available documented evidence. Did a genuine trauma probably occur? Did a genuine documented injury occur? Does the injury still exist? Then we have to consider pre-existing apportionment. It's very important, very incumbent upon us to consider also psychosocial issues to the limit that we can reasonably obtain that information. Yellow flag issues, that is, a person is complaining of medical conditions, they're not a straight out malingerer. They either do genuinely believe or know that it's not really the case, but there are other factors going on in the person's life that makes it very impelling for them, other than straight out cheating, very impelling for them to remain more ill, more disabled than they might be. And we also need to consider unrelated medical conditions which are causing similar yellow flag situations. Today's most important slide is causation. It's very important that we should obtain evidence, that is the medical data, when determining whether the condition that's being claimed is pre-existing or a genuine new injury and therefore compensable under the new circumstance that occurred at work or in a motor vehicle accident, etc. It's very important that we need to spend extensive time on the past history. Many IME doctors ask a very brief question: have you ever had any medical problems before? And the great majority of claimants when presenting will just say no, or oh yes, I had an appendix out 30 years ago. And many doctors feel that if they can just skip past asking the medical history, it just makes the job a lot easier. That's true, it does, but unfortunately it results in us often missing what's really going on here. Again, maybe yellow flag issues, or that the condition that's being claimed was actually pre-existing if we ask sufficient questions, not just ask the simple question, have you ever had pain before? So spend extensive time on the past history, including looking for apparent yellow flag issues, psychosocial issues, to compare with the current situation. And also what I would suggest we could call the Big Bang Theory. That is, finding out a huge amount of information about the first brief period immediately after the accident. If we can find out all the details, did the person get up, did they see a doctor, did an ambulance attend, did they go to a hospital, what happened in hospital, what was the first, what are the details from the first GP consultation, etc. All of the information from that first period is extremely important to obtain in fine detail. So yellow flag issues, many doctors, including myself, spend a huge amount of time reviewing the psychosocial and previous medical conditions. Some of us spend up to 50% of the sometimes extensive time that we're spending with a person on the pre-existing medical conditions and on the psychosocial factors. And it can affect up to 50% or maybe even more than 50% of medical opinions if you obtain substantial background information on the person. So you can use the documentation provided and the intensive history taking from the claimant who's sitting opposite you. I strongly recommend obtaining the past history and employment history and social history before discussing the claimed injury. There are several reasons why it's important to obtain the past history before we get the details of the person. One is that unless we actually have an understanding of how that person was before, it's very difficult to understand the impact of the new accident. Secondly, if we don't ask that information beforehand, we often can get so caught up in the details of the accident and its subsequent treatment that we'll forget to get the important information before. But the first point that I made is actually the more important one, that we're able to assess the impact of the accident much better when we're hearing about the details of the accident if we knew how the person was prior to that accident. So in assessing for causation, it's very important to get the pre-accident history. We can obtain that from many sources, including, of course, from the claimant, him or herself, but there's information from the past history sometimes recorded in a claim form, and if it's available, in the treating doctor's medical records of the past history, but also when we're speaking to the person themselves, to obtain from them specific questions about major illnesses in the past, operations, hospitalizations, previous fractures. I often use the word broken bones because many people actually don't understand that there is no difference between fractures and broken bones. And also specifically asking questions about past and even subsequent compensable injuries, workers' compensation, motor vehicle accident, or any other claimable injuries, such as slipping over in a supermarket. And of course, obtaining specific information about regular medication that they're taking for unrelated diseases. Furthermore, it's very important to obtain extensive information about the post-accident evidence. I commonly will write in my report, when providing the details of the accident, that the evidence that the trauma was or was not of a major kind includes the following, and then I'll list off that evidence in dot points. So I'll describe the accident itself in dot points rather than in full paragraphs. I also, while I'm talking about it now, commonly will provide a whole section at the end of the report after the diagnosis and opinion section, listing off again all the evidence that I've accumulated throughout the whole of the body of the report. With evidence, we can sometimes be provided with so much information that you don't even know where to go or how to deal with it, and so much of it might seem conflicting, and so much of it might seem to make little medical sense. There may not appear to be much of a consistency between the description that the person gives and the sorts of injuries that they're claiming to have occurred. So I always recommend to use an imaginary step-back test. That is, sort of take one step backwards, figuratively, in your mind, and say to yourself, when you're stuck in this, what's my gut feeling? Using my art and science of medicine, what would I really feel is present here? Because otherwise you can be so confused that you don't know where to go. And if you take that step, then very often it's clear which way you think the report should go based on all of the information you've accrued. And of course, it's very important to use your forensic skills. For an example, obtaining the information of the accident using a motor vehicle accident, it's very important very often to quote from the extensive documentation, the contemporaneous documentation obtained at the time of the accident. In a motor vehicle accident, there will often be an ambulance report that you can quote from extensively, a police report that can actually describe the real details of the accident itself, and then if they went to hospital, not only obtain the discharge summary from the doctor, but also look at the triage notes. Very often the nurse's triage notes are very informative, explaining what happened before a claimant made when they went to hospital. And of course, quoting from the doctor's records and the x-ray reports, including listing off what x-rays were not deemed to be necessary, because very often the areas of claimed injuries can expand massively, whether genuinely or not, as time goes on. So if certain areas of the body were not investigated during those initial several hours in hospital, then presumably there was not a major injury to the areas not investigated. And of course the GP's initial records. What did the GP describe the first day or what did the claimant, the GP's patient, describe on the day that the accident occurred compared to what might have been expanded upon several weeks or months later. Now I'm going to be quoting from this book. This book is written and compiled by the same American Medical Association editorial group and doctors as compiled the various versions, the various editions of the AMA guides that we use for assessment of permanent impairment. So this book, AMA Guides to the Evaluation of Disease and Injury Causation, published by American Medical Association, this is now the second edition, published 4 years ago, is excellent. It's not an opinion piece at all. It consists of a huge number of chapters, and at the end of each chapter is a whole list of references on which the information, not opinions, information in those chapters is based. So I'll be referring to that book several times, and where I give page numbers on my overheads, it refers to that book. The book itself, it had, this particular edition had 53 contributors and 29 reviewers, many of whom were editors, contributors and reviewers of the 5th and 6th editions of the AMA Guides to the Evaluation of Permanent Impairment. So the permanent impairment editors are many of them are similar to are the same as the authors of this book. So 3 of the 4 editors were variously editors, contributors or reviewers of AMA 5 and AMA 6. This can be purchased through the AMA store, that is the American Medical Association store, or from Amazon. Unfortunately, at the time of presenting this video, it's still not available from Australian co-op bookshops, but it is available easily online. There are thousands of references, including systematic reviews, meta-analyses, prospective studies, and randomised control studies. We only have time today to discuss the spine and upper limb conditions, but the book covers many more areas than that. And the introductory many chapters are dedicated towards describing, again, something that we should all know as doctors. Many of us might be a little rusty in it: statistics, evidence-based, how to assess for reliability of research, etc. All emphases in the quotes that are going to appear in today's video are my emphases. Please don't shoot the messenger. I am giving the information recorded based on the evidence in this book. These are not personal opinions. This is all quoted from the book. So the book, first of all, introduces itself by describing the fact that there is poor quality research in a number of the areas that we're interested in. That is causation in compensable injuries. The book says correctly that causation of musculoskeletal disorders has been controversial, in a large part owing to the huge quantity of papers, but with relatively poor quality. And there are a few prospective cohort studies. Samples are small generally in the research done, and exposures are rarely well measured. Typically there are many biases in the research papers, and the confounders are generally only partially controlled. Nevertheless, there is sufficient information in the research to be able to come to a number of conclusions, as you will find out today. So this is in contrast, of course, to the extensively large-scale prospective studies, for example, of cancers and cardiovascular disease and so on, which are very, very well researched. Nevertheless, steps to assess causation. There are several steps to assess work-relatedness. And the book correctly says, because these are steps, they must be performed in order. And the failure of one step should stop the process of further evaluation, because once it's failed, any further steps are irrelevant. I won't go through all of those steps one by one, but they are all steps that in theory we should always be undertaking anyhow in our clinical practices. But when providing a medical probability, we should only refer to medically probable causation, that is more than 50% likelihood. If it's less than 50% likely, then it is unacceptable when assessing for causation for compensable injuries. So terms used in these causation guides, I think there are 7 levels, from very strong evidence down to it's never been studied. So there can be evidence can be for or against the potential risk factor. For example, there can be very strong evidence against a particular issue being a cause, or very strong evidence for the condition being a cause, as you shall see in some of these slides. So first of all, I'll briefly refer to the cervical spine, how this book on causation refers to the cervical spine. Neck pain. Exercise and neck pain. There is strong evidence that there is no relationship between exercise and neck pain. Past history of neck and shoulder symptoms. There is a strong association between neck pain in multiple studies. So if there has been a past history of neck or shoulder symptoms, there is a much greater likelihood of a person again complaining of that condition than if there has not been a previous history. Gender, neck pain there is strong evidence that neck pain occurs significantly more commonly in women than in men. Now, radiculopathy. Cervical radiculopathy, there was a major study, a 10-year study of all US military population, 13 million personnel, 13.8 million personnel, amazing, don't know how they did it. And the outcome over a 10-year period was that junior personnel, despite the fact that they did the most physically demanding jobs, had the lowest rate of cervical radiculopathy compared to senior officers' jobs who typically did less physically demanding work, yet there was a much higher risk of getting neck radiculopathy, and therefore age and not physical activity is the main risk. In radiculopathy, females incidentally have a greater risk of cervical radiculopathy. Lumbar spine, specifically low back pain. Most authors today agree that despite modern medicine, the pain-generating structure for most adults with low back pain still cannot be reliably scientifically established. No surprise to the majority of us who are doing IME work. While there are published articles on facet pain, disc pain, sacroiliac joint pain and so on, there's no agreement on how these syndromes can be reliably diagnosed, and most of the low back literature uses the terms non-specific low back pain or low back pain. So in other words, with low back pain, although there are many published articles on facet pain and disc pain and so on, there's no agreement on how these syndromes can be reliably diagnosed, and most of the low back literature uses the terms non-specific low back pain or some other non-specific term because of the difficulty in diagnosis. In recent years, our understanding of genetic influences on the risk of disc degeneration has changed dramatically the traditional views. More current research, primarily studies of twins and so on, suggests that physical loading specific to occupation and to sport only plays a relatively minor role in disc degeneration. Disc degeneration is now considered a condition that is determined largely by genetics, not activity. So as a result, previous interpretations of the effects of heavy physical loading on changes in the disc have been challenged, but they still remain inconclusive, according to the research. Again, in low back pain, in general, pathology on MRI has shown little relationship to symptoms or disability, and we all know that, of course. There's currently no consensus regarding the association between lumbar degenerative disc disease, identified on scanning, and low back pain. So, with low back pain, more specifically in terms of today's discussion on causation in compensable injuries, there is insufficient evidence still that heavy work is a risk factor for low back pain. And there is insufficient evidence that awkward postures at work can be a risk factor for low back pain. There is also insufficient evidence for an association between either trunk flexion and low back pain or twisting and low back pain. There is strong evidence that sitting at work is not associated with low back pain, so that the office worker who claims that prolonged sitting was the cause of the back pain, excuse the bad pun, doesn't have a leg to stand on. Low back pain, there is strong evidence that standing and walking fewer than 2 hours per day is, again, not associated with low back pain, and there is insufficient evidence that more than 2 hours of standing and walking can cause back pain. However, as we all know, there is strong evidence that there is no association between age and onset of low back pain, and there is strong evidence that any past history of low back pain is a risk factor for low back pain in an occupational setting. So that if somebody comes to a job and has had a past history of significant back pain beforehand, there is a significant risk, of course, of that recurring. And there is strong evidence that exercise behaviour and leisure activities are not associated with low back pain. So this is contrary to commonly held beliefs. Low back pain, despite this, there is also strong evidence for an association between trunk flexion and rotation and work absence. So we know that even though those activities do not actually cause significant low back pain, nevertheless, those sorts of jobs are commonly associated with people staying away from work for whatever reason. And what about job satisfaction and psychosocial issues? There only appears to be a weak association between job satisfaction and low back pain, and there is insufficient evidence for an association between job satisfaction and work absences. So a lot of commonly held beliefs don't hold up with the research. The level of exposure to physical load was not associated with the occurrence of low back pain, but was a risk factor for sickness absence due to a complaint of low back pain. In other words, people are dissatisfied with the types of work they're doing. It's not necessarily genuine that they're requiring the time off work because of a genuine newly formed back complaint, but it does cause them to want to stay away from work. Low back pain, when organisational aspects of work, including job security, time pressure, conflicting demands, work control, quantitative demands, qualitative demands and skill discretion, etc. were considered, results were variable. Well, that was a long sentence to come to no conclusion. There is insufficient evidence for organisational aspects of work as a risk factor for low back pain based on the conflicting evidence. And there is insufficient evidence that work stress is associated with an increased level of genuine low back pain. So, and importantly, none of the studies considered found any physical factor that can reliably predict which patient with back pain will go on to develop chronic disabling back pain. The single best predictors were psychiatric comorbidity and somatization or chronic widespread pain, that is coexisting pain in places other than the lower back. So there are psychosocial factors, if we may say, and other unassociated factors that are far greater predictors than any particular physical factor that we might be able to reliably use to predict the onset of back pain. Intervertebral disc protrusion. There is insufficient scientific evidence to attribute the cause of a lumbar disc herniation to any minor trauma event or ergonomic risk factor. The cases in which there is just a temporal association, that is in time, between an event and the onset of sciatica from the disc herniation logically represent when the herniation occurs, but not why it occurs. This again is what we referred to before as the post hoc ergo propter hoc. That is, for example, as I entered the grocery store parking lot, a part in my 9-year-old car broke, therefore the grocery store injured my car and should be responsible for fixing it. That's of course nonsensical, as is nonsensical commonly the association that many lay people place on the onset of back pain and work. Low back pain, intervertebral disc protrusion. Similarly, there is insufficient evidence for an association between strenuous work and an intervertebral disc protrusion. Insufficient evidence. Of course, it doesn't mean that it doesn't exist, but it's been researched massively, and there's still insufficient evidence to confirm that there is such a relationship. Now we're going to change to the upper limbs, and I'll just skim through it. But once again, this book has extensive information, and for anybody who's doing IME work, and I have no association with the AMA guides or this book, but I do strongly recommend it as a wonderful resource text for anybody who needs to consider causation in compensable injuries. So this, the book refers, in assessing upper limb conditions, it assesses the following risk factors: vibration through the arms, high repetitive work alone, high repetitive work combined with other factors, forceful work, awkward postures, keyboard activities, cold environment, length of working in that particular job, or a combination of risk factors, the dominance of a hand, and it also assesses, in terms of the upper limb, non-occupational factors such as age, BMI, gender, biosocial factors, diabetes. That's a very important one, as we'll see, and as many of you will already know in some circumstances. So diabetes and smoking. I'll just go through briefly some of the common conditions. Ganglia of the wrist. There is insufficient evidence of any of the above occupational or non-occupational risk factors as being a causative feature of ganglia. Trigger digits. Vibration. There seems to be some evidence that vibration, that trigger digits occur more commonly in people who are working extensively with vibration. Keyboard work. There is insufficient evidence that keyboard work is a precipitating cause for trigger finger. And diabetes, there's very strong evidence that trigger finger occurs far more commonly in diabetics. De Quervain's disease, there is some evidence that highly repetitive work is associated with de Quervain's disease. Keyboard activities, low risk evidence, which therefore means it's not at all certain. Increased age, de Quervain's is clearly occurring more commonly as we grow older, and there's strong evidence that occurs more commonly in women. Dupuytren's contracture, keyboard activities, there's insufficient evidence that Dupuytren's contracture can occur with keyboard activities, but there's strong evidence that it occurs more commonly in people who are using jackhammers, etc. Osteoarthritis of the thumb, of the carpometacarpal joint. There is some evidence for awkward postures, long-term awkward postures being associated with osteoarthritis, but with keyboard activities, again, there is insufficient evidence that keyboard work can cause osteoarthritis. There is very strong evidence for constitutional situations, that is age and genetic factors, and some evidence that osteoarthritis occurs more commonly in obesity, I don't know why, and it occurs more commonly in women than men. Lateral and medial epicondylitis, there is insufficient evidence that highly repetitive work can cause epicondylitis, and there is insufficient evidence that keyboard work can cause lateral epicondylitis. Carpal tunnel syndrome, most of us would be aware that, well, I'll talk about the constitutional conditions in a moment. With carpal tunnel syndrome, forceful work, prolonged forceful work, there appears to be very strong evidence for this. However, there is highly conflicting evidence whether highly repetitive work does or doesn't cause carpal tunnel syndrome. Keyboard activities, there is insufficient evidence that keyboard activities, that a typist is more at risk of carpal tunnel syndrome due to the nature of the work than a person of the same age and gender who is not using keyboard extensively. However, with carpal tunnel syndrome specifically, there are many non-occupational factors. There is strong evidence of diabetes, very strong evidence that there's of an association between diabetes, and of course very strong evidence of an association between carpal tunnel syndrome and thyroid diseases, and of course very strong evidence of carpal tunnel syndrome in other upper limb disorders, osteoarthritis, rheumatoid, or previous fracture, etc. It also occurs far more commonly in women than men, as most of us know, etc. So there are many strong constitutional factors separate from the work-related factors, which are far less common, and so on. Shoulders. I'll just deal briefly with shoulders. Tendinopathy, impingement, rotator cuff tears, etc. Occupational risk factors, first of all. Surprisingly for me, or perhaps not so surprisingly for many of you, awkward postures and sustained shoulder postures with greater than 60% flexion or abduction, there's strong evidence of association between work that involves prolonged use of the arm suspended and various shoulder tendinopathies and tears. Highly repetitive work, there is only some evidence. Forceful work, there is insufficient research evidence of an association between forceful work and the various shoulder tendinopathies. Keyboard activities, there is insufficient evidence, and so on. However, non-occupational factors, as we all know, there's a very strong evidence of relationship between increasing age and the various shoulder tendinopathies. Obesity, diabetes, there's some evidence, and so on. So there are strong non-occupational risk factors as well. Now, this book refers also to how we deal with the concept of apportionment. We're commonly asked to give some advice, I'll use the word opinion in this case, on how to apportion a particular condition between various factors, for example, work-related and non-work-related factors, or a work-related factor followed by a car accident that occurred after the person had been doing a particular level of work, and how to apportion. The AMA 6, the 6th edition of the guide, which many of us don't use really in the jurisdictions in Australia, nevertheless, it gives us a pointer on how to consider apportionment. It states, I think appropriately, that only probable causes, at least more probable than not, should be included when assessing apportionment. So if there's less than 50% likelihood that a particular event was the cause of the current complaint, then it should not be part of the assessment of apportionment. Very important factor that many people perhaps have not picked up on. So apportionment, the 6th edition, or the 5th edition actually says, first consider all potential causes, congenital, genetic, constitutional, lifestyle, prior trauma, subsequent trauma, and the subject accident we're looking at. Probable causes are included in the apportionment, but possible causes are not. Whatever percentages are selected should be logical and defensible, that is, consistent with the medical literature and facts of the case in question. Well, gives us a sort of a statement, I guess, not particularly surprising, but the next statement is a little bit more helpful. When recording apportionment, a physician must also provide the basis for that opinion. The opinion of an expert is no better than the reasons upon which it is based, and explain the reasoning, the pertinent facts, the history and the examination. Don't just apportion it, but give the reason why you would give more weight to this than to that, and why you would give no weight at all to a condition because it's less likely than 50% to be a proper possible cause. Don't be speculative, don't just assume that you're just guessing, but give reasons, and apportion with reasonable probability, not possibility. So very briefly, apportionment is estimated by the information in the research and the exposure of the injury if it's a chronic injury, or the intensity of the trauma if it was an acute injury. However, the AMA guide states, when apportioning impairment of a body part or organ system, any pre-existing rating is subtracted from the current percentage to obtain the net impairment due to the injury disease in question. There's a lot of words. Basically, many doctors, when doing IME work, are comparing the effect of a new injury on the level of injury that had been present beforehand. For example, a person had a previous injury to their back, and now they've had a new injury to the back, but the previous back pain had persisted. And they might take the easy way out by saying, well, it's about 50-50. However, if there had been a certain level of permanent impairment beforehand, let's say 5% permanent impairment, and the person has now got the same pain, the same amount of impairment, but there was a new episode of pain, if there had already been 5% permanent impairment beforehand, the new accident has resulted in 0% increased permanent impairment, not 2.5% permanent impairment. In other words, not to be split equally. If there was pre-existing impairment, that impairment was the baseline on which the new injury is assessed. It's a very important factor. It might seem quite obvious, but a huge number of doctors, as I can see, fall down on that situation. The AMA Guide's book on causation also, in addition to discussing apportionment, discusses the concept, or at least reviews the research on favouring or overuse of the opposite limb. So somebody's had pain in the left shoulder from a particular claimed injury. The right shoulder wasn't injured during that accident, but the person starts to complain of pain in the right shoulder now, the opposite shoulder, and the claim is that overuse of the injured left shoulder has resulted in the right shoulder being more active and now being injured indirectly as a result of that original accident that injured only the left shoulder. So what does the research say? The reference text here, the AMA Guides to Causation, states that the concept that favouring one upper limb can result in injury or illness in the other is not based on scientific evidence. Instead, it is an unsupportable myth. Now that sounds like it's an opinion, but that paragraph is based on a huge amount of research, the references of which appear at the end of the chapter on the question of overuse and favouring. For example, the reference text states, epicondylitis. The British Systemic Review of Upper Limb and Elbow Tendinitis and Tendinopathy did not find evidence to attribute the development of elbow tendinitis to ergonomic exposures. Currently, there is insufficient evidence to support favouring as a probable cause for symptom onset in the originally uninvolved elbow of epicondylitis. As we know, many conditions are constitutional, and therefore if it's going to occur on one side of the body, there is a significant risk that it's also going to occur on the other side, just because of the constitutional factors, with or without injury to the opposite body part. Similarly, in favouring carpal tunnel syndrome, the reference text states, idiopathic carpal tunnel syndrome is commonly bilateral because it's a constitutional condition. In 87% of cases in one particular series, if carpal tunnel syndrome occurred in one side, it occurred in the other side eventually. And it's difficult to prove, therefore, that symptoms that began on one side caused similar ones in the other side. Somewhat similarly, shoulder conditions, including rotator cuff. The reference text looks at review articles and research and states, the articles reviewed do not support favouring as a reasonable cause of development of symptoms in the contralateral shoulder. There is no scientific support for the concept that having symptoms in the first limb causes an increased rate of disease in the second limb. Similarly, in the lower limb, on review of the medical literature, the reference text states, review of the medical literature reveals no generally accepted studies that support such a causal relationship, nor is there any reasonable scientific logic therefore. So what does all this mean? Local legislation can alter our definition of causation. However, there is some science to the evaluation of causation. It's not complete, the science, but it does give us direction. Apportionment can be assessed, but we must only consider probable causes, that is, more than 50% likely that this particular issue caused that injury. And we should not just consider possible causes, that is, less than 50% likely to have been a cause. It's essential for us to obtain a full past history when assessing causation, and it's essential for us to assess a full history of the claimed injury, the fine details, including the initial Big Bang, first microsecond. Injury of the opposite limb from favouring, as referred to in this causation reference text, is an unsupportable myth. Always give reasons, that is the legal term, for our evidence, the medical term, because opinions without reasons are useless. Thank you.